Bismillah ar-Rahman ar-Rahim. Good day, everyone. I'm Dr. Mahmoud Sheikh. Now we are shifting to anti-glomerular basement membrane disease, one of the most aggressive and dramatic autoimmune conditions we deal with in nephrology. This summary is based on the work of Stephen McAdoo and Charles Bussey, recently published in Nephrology, Dialysis and Transplantation. This review really lays out where the treatment standards stand today and how new approaches are starting to reshape our management. It's a disease that moves fast, so our therapeutic decisions have to move just as fast. Throughout this talk, we will walk you through the current best practice strategies, the evidence behind them, and where emerging treatment may fit in. This sets the stage for understanding how we can improve outcomes in conditions that doesn't give us much time to act. Let's break down the disease mechanism because understanding this biology is what makes anti-GBM diseases so uniquely aggressive. On the pathophysiology side, the entire process centers around alpha 3 type 4 NC1 antigen, normally tucked away and protected within the NC1 hexamer of type 4 collagen. Once it becomes exposed, the immune system goes after it. Two key B-cell epitopes known as EA and EB seem to drive disease severity. Two autoantibodies don't just hit one chain, they target the alpha 3 and alpha 4 and alpha 5 chains of type 4 collagen. That's why the injury is so dramatic. It hits both the glomeruli and alveoli. Clinically, the presentation is almost always explosive. More than 90% of patients comes with rapid progressive GN, and around half will have alveolar hemorrhage. The diagnosis relies on a combination of clinical features, biopsy showing that classic linear IgG deposition along the GBM, and serology demonstrating circulating anti-GBM antibodies. And the key point here is urgency. Without treatment, the disease is uniformly fatal. Everything about NGBM pushes us toward rapid recognition and immediate intervention. Now, let's talk about the key diagnostic considerations. Because NGBM disease is one of those conditions where early accurate identification changes everything, we start with serology. Modern immunoassays can detect circulating antibodies against the alpha 3 type 4 NC1 antigen in over 90% of patients. Sensitivity and specificity are excellent. What really matters clinically is that about 30 to 40% of patients are double positive for ANCA. That subgroup behaves differently. They have a higher relapse risk and often need a more nuanced treatment plan. Next is immunohistology, which remains a true diagnostic gold standard. Of frozen sections, immunofluorescence shows that classic strong linear ribbon like IgG staining along the glomerular membrane. It's an instantly recognizable pattern. Sometimes you will also see complement, particularly C3, but the hallmark is the linear IgG. And then we have the kidney biopsy itself. It's more than 80% of cases you see diffuse crescentic GN, usually affecting around 75% of the glomeruli. One detail that's clinically useful: in pure anti-GBM disease, crescents tend to be more of uniform, same age. When you start seeing mixed acute and chronic lesions and different ages, that raise suspicion for a concomitant ANCA-associated process. Altogether, these three pillars, serology, immunofluorescence, and biopsy pathology, gives us the complete diagnostic picture. This slide highlights the absolute cornerstone of anti-GBM treatment, plasma exchange. Everything we know about the disease pathophysiology points to the circulating antibodies as the main driver of injury, so removing them quickly is very critical. Plasma exchange became standard after Lockwood's landmark study back in 1976, which showed that PICs can rapidly clear anti-GBM antibodies, improving lung hemorrhage and even salvage kidney function in patients who aren't yet dialysis dependent. That early data has held strong for decades. In practical terms, each exchange session removes about 50 to 60% of circulating IgG, assuming you are doing a one-to-one and have plasma volume exchange. And despite how aggressive the disease is, survival can be quite good when therapy is started very early. About 87% 1 year survival in a French cohort of severely ill patients, most of whom were already dialysis dependent. And when it comes to the number of the changes, the evidence consistently points to 8 to 10 sessions as the range associated with most favorable outcomes. That lines up with both ASFA and KDIGO recommendations. The key operational point is timing. Daily treatment is recommended because only about 45% of total IgG is intravascular. The rest redistributes back into the bloodstream over the next several hours, so daily sessions allow you to keep pulling antibodies down as they re-equilibrate. So overall, plasma exchange isn't just an add-on therapy, it is the core intervention that changes the trajectory of this disease. Now let's move into the practical side of PECS, the protocol and day-to-day consideration that really determine outcomes. First, the treatment schedule. We typically perform a daily exchange at 40 to 60 ml per kilogram using a 5% albumin solution as a replacement fluid. Treatment continues until the anti-GBM antibodies levels are fully suppressed, and that usually takes around 14 days. In certain situations, especially if the patient has alveolar hemorrhage or is about to undergo an invasive procedure, maybe like biopsy. So we add fresh frozen plasma, usually at the range of 300 to 600 ml to restore coagulation factors. One of the key operational points is frequent monitoring. We follow antibody levels closely both during therapy and after stopping because some patients do show a rebound, and in that case, plasma exchange may need to be restarted again. Next are the monitoring requirements. We aim to keep hemoglobin above 9, platelets should be over 70, and fibrogen should be monitored and stay above 1 gram per liter. And if it drops, we may need to give cryoprecipitate. Calcium also needs to be corrected and maintained in the normal range because citrate anticoagulation can drive hypocalcemia. On the right side are the key complications to keep in mind. Access related issues like infection, thrombosis are common, especially in critically ill patients. Hematologic problems, particularly bleeding risk and coagulopathy, also matters given the volume shifts and the removal of coagulation proteins. And metabolic issues such as hypocalcemia and other electrolyte changes need to be anticipated and treated promptly. A couple of practical pairs at the bottom. Both centrifugal and plasma filtration techniques are effective in clearing IgG, so either modality is acceptable. And finally, when you are giving immunosuppression, especially cyclophosphamide, the timing matters. Always give the dose after hemodialysis or after the PEX session to avoid unwanted removal. Here we are looking at the immunoabsorption, which is becoming a promising alternative to plasma exchange. The idea behind immunoabsorption is simple. Instead of removing the entire plasma volume like we do with PEX, we run the plasma through an absorber column that selectively removes pathogenic IgG while maintaining IgM and IgA and preserving most of other plasma components. Recent data shows that over about 7 sessions, immunosuppression can achieve antibody reduction comparable to PEX. The advantages are worth noting. It tends to produce greater overall reduction in total IgE, yet it preserves IgA and IgM, which can make difference in immune stability. There is also a lower risk of extrapulmonary bleeding, and patients usually require fewer transfusions. In terms of both overall survival and kidney survival, the outcomes are similar to PECs. We also have meaningful clinical evidence. A large nationwide German study with more than 900 patients showed that centers using immunoabsorption in about 11% of cases achieved outcomes comparable to plasma exchange but with a better overall safety profile. So the take-home message is this immunosuppression is a solid alternative when it's available, especially in situations where reserving plasma components is important, or when minimizing transfusions needs is a priority. Cyclophosphamide remains the first-line immunosuppression therapy of anti-GBM disease, and most centers still rely on daily oral dosing. The standard dose is about 2 to 3 milligram per kilogram per day, with a maximum of 200 milligrams. That's the most widely used regimen worldwide. In older adults and in patients who are dialysis dependent, we usually start lower, somewhere between 50 to 100 milligram a day, and then adjust based on tolerability of the patient and renal function. Treatments typically run for about 2 to 3 months, just long enough to suppress antibody formations through the acute phase. Now, the question often comes up, why oral and not IV? The rationale is actually very straightforward. Cyclosamide is water soluble and small enough that it can theoretically be removed by dialysis or by PEX before it's metabolized. With daily or oral dosing, you get more consistent drug exposure compared to pulsed IV dosing, especially in patients who are undergoing extracorporeal therapies. Retrospective data even suggests better outcomes with the oral route. On the toxicity side, we have several key issues to watch for. Bone marrow suppression is the most important. You need to stop treatment if the white count drops below 4 and restart at a lower dose once it recovers. Urolithial toxicity is also a concern, so hydration and frequent voiding are essential, especially in patients who are still making urine. We also need to think about infertility, so gamete reservation should be discussed, particularly with younger patients. And of course, there is a long term risk of secondary malignancies, which means these patients need ongoing surveillance. The main practical take home is that nearly all published experience uses daily oral dosing of cyclophosphamide, and because anti-GBM disease has such a lower relapse risk compared to ankylosing, concerns about cumulative lifetime doses are less of an issue in such context. Glucocorticoids remain an important part of the treatment strategy in anti-GBM disease, but the dosing is much simpler than what we use in ankylosing. In the initial phase, we usually start with prednisolone at 1 milligram per kilogram per day, up to a maximum of 60 milligrams. The key point here is that we don't need a higher dose IV steroids if PEX and cyclosamide are started promptly. The evidence just isn't there. From weeks 1 to through 6, we gradually taper the dose, aiming to reach 20 milligrams by week 6. After that, the taper continues slowly through months 2 to 6, with the goal of complete discontinuation by 6 months. Whereas there is no evidence supporting the reduced dose regimens used in ANCA-associated vasculitis, and GBM is a different disease with a different relapse profile. Now, because these patients receive both steroids and cytotoxic therapies, prophylaxis is essential. We cover for pneumocystis with cotrimazole, and we protect against oropharyngeal fungal infections with agents like nystatin or fluconazole. We also use proton pump inhibitors to prevent peptic ulcer disease, and we address bone health with calcium, vitamin D, and sometimes bisphosphonates. For patients with history of hepatitis B, we also gave lamivudine prophylaxis to prevent reactivation of this latent infection. So overall, the steroid regimen is straightforward, but the supportive therapy has to be done carefully. It's a big part of keeping these patients safe during treatment. Retox is not a frontline therapy in NGBM disease, but it's becoming an important adjunct option in carefully selected situations. As a CD20 directed monoclonal antibody, it works by depleting circulating B cells, which reduce antibody production at the source. Even though published experience is still limited, the data we do have are very encouraging. In an international review of 67 patients treated with Retox, patient survival reached 91%. Kidney survival, whether Retox was used as a first line or second line, was around 67%. And importantly, adverse events were relatively low, about 16%, and mostly mild or transient infusion reactions. So, how do we use redox in practice? Typically, in scenarios where there are strong contraindications to cyclophosphamide, or when we want to limit cumulative alkylator exposure. It can also be considered as an adjunct in severe diseases or as a bridge for patients awaiting kidney transplantation. The key typical dosing regimens mirror those used in other autoimmune disease. Two doses of 1 gram given on day 0 and day 14, or the alternative 375 milligram per square meter weekly for 4 weeks. One key procedural point: plasma change should be delayed 24 to 48 hours after detox infusion to avoid removing the drug before it can work. And the adequacy of B cell depletion can be monitored using CD19 counts. Overall, detox isn't replacing cyclophosphamide, but it's expanding our therapeutic toolbox, and for the right patient, can make a real difference. Now let's walk through the treatment indications and situations where therapy may become futile, something that's critically important in anti-GBM disease because timing is everything, starting with alveolar hemorrhage. When it occurs, it's life-threatening, but fortunately, it's also one of the most treatment-responsive features on this entity. Between 90 and 100% of patients can achieve remission when therapy is started promptly. And the key point is we always treat when alveolar hemorrhage is present, no matter how advanced the kidney disease is. Lung involvement is an absolute indication. On the prognosis side, things look very different depending on whether the patient is dialysis dependent at presentation or not. Patients who are not on dialysis have excellent outcomes. 1 year renal survival ranges from 95% when creatinine is below 500 micromoles per liter, down to 82% when creatinine is above that threshold. 5 year survival remains strong at 94% and 50% respectively. But for dialysis dependent patients, the numbers are much more sobering. Only about 8% recovered independent kidney function at 1 year, and even the most optimistic recovery estimates land around 17 to 20%. And the biggest predictor of fertility is if the patient has been on dialysis for more than 7 days before treatment begins, recovery becomes exceedingly rare. Finally, we look at the histopathological predictors. Certain biopsy features really helps to guide the conversation. If there are 100% crescents, recovery hasn't been observed in dialysis-dependent patients. If more than half the glomeruli are sclerosed, recovery also hasn't been seen. On the flip side, the fewer normal glomeruli and the more interstitial inflammation you see, the higher the likelihood of ending up with end-stage kidney disease. And among all clinical parameters, oligoanuria is the strongest predictor for non-recovery. So in anti-GBM disease, the treatment decision hinges on speed, lung involvement, dialysis duration, and the biopsy story, all of which help us to balance aggressive therapy with realistic expectations. Now let's talk about when we should treat patients who are dialysis dependent. This decision is always challenging, and our goal is to identify who still has a real chance of recovery. We usually begin with the biopsy. If the biopsy shows less than 100% crescent and less than 50% glomerulosclerosis, that suggests that the kidney may still recover. So, biopsy finding can be our first signal that treatment is worthwhile. Next is the clinical presentation. Dialysis-dependent patient who is not oliguric or one whose dialysis requirement is explained by a reversible problem, like severe acute tubular injury, may still respond to therapy. Timing also plays a big role. If dialysis was started recently, usually within 72 hours, we need to carefully consider the reason. Was it hyperkalemic? Was it anuria? Because early dialysis initiation might still leave a window where treatment can help. Then we have double positive patients who are both ANCA positive and anti-GBM positive. These patients have a higher chance of recovery compared to classic NGBM alone. And finally, an individualized approach for younger patients who can tolerate immunosuppression and have a lower risk of adverse events. Offering a short trial of therapy can be reasonable. In the end, even though recovery is rare in severe cases, decisions must be individualized. Short-term immunosuppression may help with antibody clearance and can even improve access to earlier kidney transplantation, even without renal recovery. This is very important. So the key idea is this: don't treat every dialysis-dependent patient as the same. Use the biopsy and the timing and the presentation and the patient's tolerance to guide who might still benefit from therapy. Now let's move to supportive care and organ support. Because in anti-GBM disease, these supportive measures often makes the difference between stabilization and rapid deterioration. First, we focus on immediate organ support. About half of patients will need some form of acute renal replacement therapy right at diagnosis. Around 11% of patients with alveolar hemorrhage will require a mechanical ventilation, and in cases of severe pulmonary hemorrhage, we may consider ECMO. Interestingly, ECMO can be associated with a favorable outcomes even though it requires systemic anticoagulation, which can feel counterintuitive in bleeding patients. Next, we look at managing precipitants, especially anything that can worsen alveolar hemorrhage. Respiratory infections, pulmonary edema, and the other lung irritants can significantly exacerbate bleeding, so you need to be addressed. They need to be addressed aggressively, and patients should absolutely avoid cigarette smoking and hydrocarbon exposure because both can worsen lung injury. Then we shift to infection prevention, which is critical because these patients are receiving cytotoxic therapy and high dose steroids, a combination that dramatically increase the infection risk. So routine prophylaxis is not optional; it is very essential. That include pneumocystis prophylaxis throughout treatment, as we mentioned, antifungal prophylaxis for oropharyngeal infections, and you should examine your patient for that. Gastric protection with proton pump inhibitors just in case if any hemorrhage just happened. HPV reactivation prophylaxis in previously infected patients, and osteoporosis prevention with calcium, vitamin D, and bisphosphonates. The goal here is to keep the patient stable enough to continue with the immunosuppressive therapy that actually treats the disease. Supportive care is not secondary, it's a core part of the management. Now let's shift to relapse and long-term outcomes in NGBM disease. The good news is that relapse is uncommon. With appropriate treatment, the relapse rate is under 3%, which is extremely low compared to other autoimmune kidney disease. Before we ever think about kidney transplantation, patients need to remain seronegative for at least 6 months. This is important because circulating anti-GBM antibodies are strongly associated with recurrence after transplantation, and with modern immunosuppressive regimens and proper timing, the risk of recurrence after transplantation is below 5%, which is reassuring. When relapse does occur, it's usually linked to ongoing exposure to pulmonary irritants, especially cigarette and hydrocarbons, as we mentioned. So, strict avoidance is a key part of long term management. If a relapse happens with kidney involvement, we recommend a repeat biopsy to confirm the diagnosis and to rule out other pathologies like ANCA-associated vasculitis or membranous nephropathy. Retreatment usually follows the same protocol as the initial episode: PECs, cytotoxic agents, and steroids. Now, about transplant outcomes for patients who progress to end-stage kidney disease, long-term outcomes after transplantation are actually comparable to outcomes in patients with end-stage kidney disease from other causes. Historically, recurrence rates were as high as 50% when transplants were done while antibodies were still present. But with today's practice, ensuring sustained seronegativity and using modern immunosuppression, recurrent disease after transplantation is very rare. So overall, with strict exposure, avoidance, appropriate timing, and careful follow-up, long-term outcomes in NGBM disease are very favorable. Now let's talk about double positive disease patients who have both ANCA and anti-GBM antibodies. This group behaves very differently from classic anti-GBM disease, and understanding the overlap is essential for making the right treatment decision. Clinically, these patients look more like vasculitis in the early phase. They tend to be more older, they often have prodromal symptoms, and their kidney biopsies show more chronic changes, supporting the idea that ANCA-associated vasculitis may actually be the initial underlying process. But despite this chronic background, when they finally present, they come in with severe NGBM features, meaning aggressive lung or kidney involvement. Now, circulating ANCA are found in about 30 to 40% of NGBM cases, usually against myeloperoxidase, and interestingly, ANCA may be detectable before NGBM disease manifests. This supports that theory that ANCA-induced glomerular inflammation may trigger an NGBM response by modifying or exposing hidden epitopes in the basement membrane. For long-term management, double positive cases relapse at a rate similar to AAV, especially if they have prodromal or extrarenal features. That's why these patients need maintenance immunosuppression, just like we would do for ANCA-associated vasculitis. Single positive NGPM patients almost never relapse, but double positive cases clearly do. When it comes to treatment, we start with the standard anti-GBM therapy, PEX, cytotoxic agents, and steroids. But the double positive group is a bit unique. They seem to have a higher chance of recovering from dialysis, around 33% versus 17 in classic NGBM. So even if the patient is dialysis dependent, it's often worth considering intensive treatment, especially if the biopsy shows post-immune GN, which aligns more closely with vasculitis pathology. So, in summary, double positive disease sits right at the intersection of vasculitis and NGBM. It presents severely, behaves chronically, and relapse like ANCA-associated vasculitis, which means your management must account for both sides of the disease. Now we move to one of the most challenging scenarios in anti-GBM disease is refractory disease. Refractory NGBM refers to persistent active disease despite standard therapy. This usually means there is ongoing production of pathogenic autoantibodies, and that's what drives the continued injury. It's not common, but when it happens, it carries a higher risk of progression to end-stage disease, and in some cases, mortality from persistent pulmonary hemorrhage. One important point, there is no universally accepted definition of refractory NGBM disease, and this makes it essential to carefully distinguish true refractoriness from other causes of non-response. For example, sometimes what looks like refractory disease is actually irreversible kidney damage because diagnosis was very late, or the patient may have a pulmonary hemorrhage mimic infection, pulmonary edema, urine chemopsis, or even ARDS. Pulmonary embolism can also masquerade after refractory bleeding, especially because the VTE risk is higher during active vasculitis. And we can not forget alternative primary lung disease, such as pulmonary fibrosis, particularly in ANCA-positive patients. So, with that framework, how do we manage through the refractory cases? First, we may intensify extracorporeal therapies. This means increasing the frequency or dose of PEX to enhance antibody removal. Second, we consider augmenting immunosuppression either by increasing steroid or adding adjunctive agents if the patient can tolerate it. Third, we may add Retox. Retox can be more effective in depleting CD20 positive beta B cells, which are responsible for ongoing and autoantibody production. And fourth, we have to plan ahead for renal replacement therapy in patients with irreversible kidney injury. Supportive care becomes the primary goal, but ongoing immunosuppression may still help with antibody clearance, especially if we are preparing the patient for future kidney transplantation. So overall, refractoriness is less about one fixed definition and more about careful rolling out mimics, confirming persistent active disease, and escalating therapy in strategic, stepwise way. Now let's discuss atypical GBM disease, a rare and fascinating variant that behaves very differently from classic NGBM. These are cases where the kidney biopsy shows classic linear IgG staining, exactly like typical NGBM disease, but there are no detectable circulating antibodies, and the clinical, immunological, or pathological picture just doesn't fit the usual pattern because it's rare and often subtle. Diagnosing it requires a high index of suspicion and the willingness to adapt the diagnostic approach. One important feature is light chain restriction. About 50% of these patients show kappa or lambda light chain restriction on immunofluorescence, and recent reports of recurrent monotypic disease in kidney allografts suggest that some patients may actually have a circulating monoclonal protein, even though they doesn't meet criteria for classic monoclonal immunoglobulin deposition disease. It's a reminder that the biology can be a bit more complex than the classic anti-GBM model. Clinically, these patients tend to have milder kidney involvement and overall better outcomes compared with classic disease. You'll often see mesangial or endocapillary proliferative GN, and only about 10% have crescents or fibrinoid necrosis. And importantly, pulmonary involvement is usually absent, which helps differentiate it from typical NGBM. The treatment approach is still not well defined. Immunosuppression with steroids and cyclophosphamide or MMF can be considered depending on the severity of glomerular injury, but PEX is generally not recommended when there is no RPGN or detectable circulating antibodies. And because of the light chain findings, evaluating for dysproteinemias always be a part of the assessment. So overall, a typical NGBM disease behaves more gently than the classic form, but also takes us to think more broadly, connect subtle clues, and tailor the approach to each individual cases. Now let's look at the two unusual but important variants of anti-GBM disease, IgE-mediated anti-GBM and isolated pulmonary involvement. First, IgE-mediated anti-GBM disease is a rare isotypic variant where the pathogenic autoantibodies are IgE instead of IgG. On biopsy, you see strong linear IgA deposition along with GBM, often with minimal or no IgG staining. Clinically, these patients can present just like classic RPGN, though pulmonary involvement is generally less common. These cases come with significant diagnostic challenge. Circulating antibodies are often not detectable because most routine assays are optimized for IgG only. So diagnostic really depend on kidney biopsy with IgG immunostaining, otherwise it's easy to be missed. Treatment usually follows the same protocol we use for IgG-mediated disease: immunosuppression, steroids, cyclophosphamide, or MMF, but renal outcomes may be poor, possibly because we don't have a reliable circulating biomarker to guide us. Next, let's shift to isolated or predominantly pulmonary involvement. This happens in fewer than 10% of patients. Some individuals have mild urinary abnormalities and minor proliferative changes on biopsy while still maintaining preserved kidney function. Others may have no clinical or histopathological evidence of renal inflammation at all, so the disease can be almost entirely lung dominant. A fascinating subgroup involves the IgG4 subclasses, small Swedish series describe young female patient with severe alveolar hemorrhage but no severe renal presentation. They were seronegative on standard testing, but specialized ELISA detected circulating IgG4 and GBM antibodies. This suggests that difference in antibody subclasses or antigen target might shape the clinical pictures. In terms of treatment, the recommendations remain to use conventional intensive therapy, PEX, and immunosuppression, especially in cases with severe pulmonary hemorrhage. Overall, these variants remind us that NGBM disease is not a single entity. It can shift isotypes, shift organs, and challenges our diagnostic tools. And the key is maintaining awareness so we don't miss what the standard assays fail to detect. Now let's talk about situations where anti-GBM disease appears in association with other kidney conditions. These overlap syndromes can be tricky, and recognizing them early changes the entire trajectory of management. Let's start with membranous nephropathy. There are multiple reports of anti-GBM disease appearing before, during, and after diagnosis of membranous nephropathy. One key concept is that disruption of GBM architecture in membranous disease makes both hidden epitopes, making it easier for a second immune process like NGBM to occur. So a patient with non-membranous nephropathy suddenly has a rapid declining kidney profile that should immediately raise suspicion. A repeat biopsy is recommended in such situation. And early on, we treat these patients as true NGBM disease. Fortunately, the prognosis is better, especially when treatment begins before the patient becomes dialysis dependent. And the second scenario is NGBM disease in Alport syndrome, post-transplantation. This is a classic alloimmune response. Kidney transplantation recipients with Alport syndrome may mount antibodies against the donor's normal alpha 3, alpha 4, alpha 5 collagen type 4 chains, proteins they were never exposed to because of their underlying genetic defect. In X-linked Alport syndrome, these antibodies target a composite epitope on the alpha 5 type 4 collagen in C1 chain, and this is not detected by standard alpha 3 4 assays. NGBM antibodies occur in about 5 to 10% of these patients after transplantation. Clinically significant glomerulonephritis is less common, but when it happens, it carries a very high risk for allograft loss. Patients with large COL4A5 gene deletion seem to be at especially a higher risk, and if retransplantation is attempted, it almost always leads to aggressive recurrence and rapid graft loss because the alloimmune response is already primed. So the main message here is that NGBM disease can emerge on top of other glomerular conditions, each with a unique mechanism and a unique clinical behavior. Early recognition is the key to prevent irreversible kidney damage or graft failure. Now let's move into pregnancy and pediatric considerations, two very rare but clinically important scenarios in NGBM disease. Starting with pregnancy, NGBM disease in pregnancy is extremely rare. Systematic review from 2014 identified only 8 cases in the literature. Most presentations occur in the second trimester, and although 6 out of 8 pregnancies resulted in live birth, the rate of both fetal and maternal complications was very high. When it comes to treatment during pregnancies, steroids, PECs can be used safely throughout all trimesters, and from second trimester onward, once organogenesis is complete, judges cyclophosphamide may be considered if the disease is severe and life-threatening. We may also use azathioprine as an alternative immunosuppressant, and in selected cases, detox can be considered. Transplacental transfer of anti-GBM antibodies has been documented, but interestingly, neonates showed no evidence of kidney or lung disease. This may be related to that fact that the fetal and neonatal GBM express a different collagen for protomer, which is alpha 1, alpha 1, alpha 2, rather than alpha 3, alpha 4, alpha 5, making them less susceptible for injury. Now let's move to pediatric anti-GBM disease. This condition is rare in children, representing less than 5% of pediatric recenter GN. The presentation is often severe, with high likelihood of dialysis-dependent diagnosis. We don't have strong pediatric-specific treatment data. Most centers simply adapt adult protocols, careful adjusting plasma exchange volumes and cytotoxic dosing for body size. Outcomes in children generally mirror adult outcomes. Renal recovery is possible, but mainly when treatment is started before the child becomes dialysis dependent. However, long-term adverse effects of cyclophosphamide, like infertility and secondary malignancies, are major concerns in this age group. Retox combined with MMF has been tried as alternative in small numbers of non-dialysis dependent pediatric cases with encouraging results so far. So the key message here is NGBM disease is in pregnancy and childhood is rare, but when it occurs, early recognition and tailored therapy are essential to protect both the patient and longer-term outcomes. Now let's move to one of the most exciting emerging therapies in antibody-mediated kidney disease, imlifidase. Imlifidase, also known as IDS, is an endopeptidase driven from Streptococcus pyogenes. What makes this unique is its ability to rapidly cleave all IgG subclasses at the hinge region, splitting IgG into two fragments. This mechanism is now being explored as a way to rapidly remove pathogenic antibodies in diseases like NGBM. Let's start with the preclinical evidence. In mouse models of anti-GBM disease, IDS significantly reduce glomerular inflammation and albuminuria. A key point is that IDS can cleave GBM-bound IgG, meaning it can target antibodies that are not accessible to plasma exchange. That's a potential game changer. Next, the phase 2 results study of 15 patients with severe disease, most of which GFR below 15, showed that single dose of imlifidase cleared circulating and GBM antibodies within 6 hours. And at 6 months, 6-7 of treated patients were alive, dialysis independent, compared with only 18% in matched historic controls. This is a striking difference for such fulminant disease. There were some challenges, though. About two-thirds of patients experienced antibody rebound at around 6.5 days, requiring the addition of PEX. But overall treatment was well tolerated with no major adverse events attributed to imlifidase. Now to the phase 3 trials, the global randomized controlled trial GOD IDS 02 completed enrollment of 50 patients in 2025. It compares imlifidase plus standard therapy versus standard therapy alone in patients entering with an estimated GFR under 20. The primary endpoint is kidney function at 6 months, and results expected later in late 2025 could pave the way for regulatory approval. Maybe cost will be a limiting factor, but if outcomes replicate what we have seen in earlier phases, imlifidase has the potential to dramatically reshape how we treat severe anti-GBM disease. Now let's talk about risk stratification in anti-GBM disease because prognosis can vary dramatically, and early recognition helps us guide treatment intensity and duration and expectations. We can simplify this into three major prognostic tiers. At the top, we have patients with an excellent prognosis. These are individuals who have more than 10% normal glomeruli on biopsy and don't require dialysis at presentation. Their outcomes were remarkably strong. About 96 have 3-year renal survival. This group represents the window where aggressive therapy really pays off. And in the middle, we have the intermediate risk group. These patients have mixed clinical and biopsy features, and they require individualized assessment. Here we weigh the degree of crescent's chronicity and extrarenal involvement and how quickly the disease has progressed. This is where clinical judgment and experience really matter. And finally, the group at the bottom, poor prognosis. There are patients who arrive dialysis dependent and have fewer than 10% normal glomeruli. Their 3-year survival is only about 14%, meaning recovery is possible but uncommon. This is a population where the focus often shifts toward controlling disease activity, preventing pulmonary complications, and planning long-term kidney replacement strategies. A recent multicenter study of 174 patients, the largest histopathological data set for anti-GBM so far, validated a renal risk scoring tool originally developed for ANCA vasculitis. What they found is that the two strongest independent predictors of long-term kidney failures are the need for dialysis at the presentation and the percentage of normal glomeruli in biopsy. When we apply this clinical a 10% cutoff of normal glomeruli is extremely meaningful. It helps us separate patients into distinct prognostic categories and guide how aggressive we treat. These simple early features taken from the first biopsy and the initial clinical presentation can help us personalize therapy, choose the right intensity, and potentially improve long term kidney outcomes. So, overall, risk stratification isn't just a research concept, it's a practical tool that can meaningfully shape our decision making in those first critical hours and days. Now, let's talk about how we personalize treatment strategies in NGBM disease. This is one of those situations where the biology and the biopsy and patient's overall context all shape the treatment plan. We start with histological severity. Patients who have fewer crescents, less glomerulosclerosis, and more preserved glomeruli are the ones who benefit the most from aggressive early therapy. In dialysis dependent patients, we always combine the biopsy finding with the clinical course to decide whether full treatment is justified or not. Next comes ANCA positivity. Double positive patients tend to be older and they carry a higher risk for relapse. So we treat acute phase exactly like classic NGBM, but after that they need maintenance immunosuppression, similar to what we do in ANCA vasculitis. We also look at the individual patient's factors, things like age, comorbid conditions, treatment tolerance, and no even patient preference all matter. These influence both the intensity of treatment and how long we maintain immunosuppression. Then we have a typical presentation. Sometimes the circulating NGBM antibodies comes back negative, but the biopsy shows classic linear IgG. Those patients still need treatment. In milder or slowly progressive disease, immunosuppression alone without PEX may be enough. For contraindications, cyclophosphamide isn't always an option. Patients with severe cytopenias, active malignancies, fertility concerns may be better treated with Ritox instead. It's not first line, but in right situation, it's absolutely reasonable. Finally, transplantation planning. NGBM antibodies have to be completely undetectable for at least 6 months before moving forward with a kidney transplant. This is essential to prevent recurrence in the allograft. So when we put these pieces together, the biopsy, the serology, the clinical setting, and the patient's own priorities, you get a far more individualized and safer treatment plan. Let's finish by looking at where the field is heading, the future direction and the key unmet needs in NGBM disease. First, the cyclophosphamide routes. We still need to define the optimal way to give cyclophosphamide, whether oral or intravenous, especially in patients who also receiving extracorporeal therapies like PEX. Right now, most of available evidence support oral dosing, but we don't have strong prospective data to confirm that. This is an area where better trials would really help. Next is the role of Ritox. We need clearer data on whether Ritox can truly be used as first line agent or if its role stays mainly as adjunctive therapy. Questions remain around the best dosing, the timing relative to plasma change, and which patients are most likely to be benefit. Then we have imlifidase integration. This is one of the most exciting developments. The ongoing God ID's 02 phase 3 trial will tell us whether imlifidase can actually improve outcomes compared to standard therapy, particularly in patients with poor prognostic features, where imlifidase ultimately fits into treatment algorithm and is still to be determined. Another key issue is treatment futility criteria. We need better definition to help decide when full immunosuppression is unlikely to provide benefit, especially in dialysis-dependent patients. High-quality prospective data will help us avoid unnecessary treatment toxicity while still offering aggressive therapy to those who can truly recover. And finally, a typical disease. We need a deeper understanding of how to evaluate and manage non-classical forms of NGBM disease, including IgE dominant variants and the seronegative presentations. Both the diagnostic approach and the therapeutic strategy still require significant refinement. Altogether, these unmet needs highlights how much progress has been made, but also how much opportunity remains to individualize therapy. reduce toxicity, and improve outcomes for patients with this aggressive entity. Before we wrap up, let's bring everything together with the key takeaways. Anti-GBM disease remains one of the most aggressive autoimmune conditions we deal with in nephrology. Outcomes depend heavily on how quickly we recognize the disease and how decisively we start therapy. Over the past few decades, combination between plasma exchange with cyclophosphamide and steroids has dramatically improved survival and long-term kidney outcomes. The first big message is that plasma exchange is essential. Large cohort studies continue to refine PICS as a fundamental part of treatment. Immunosuppression is becoming a promising alternative where it's available, immunoabsorption, offering similar antibody clearance. Treatment is typical daily for about 2 weeks or until we achieve complete antibody suppression. The second message is individualized treatment decisions. The dialysis status and the severity of histological injury, and cacophobicity and the timing of presentation all shape how aggressive we should be. Risk stratification tools help us to guide the choices, and in carefully selected dialysis-dependent patients, a short trial of therapy may still be reasonable. Next, we are seeing expanding therapeutic options. Detox is an alternative for patients who can take cyclophosphamide for those with refractory illness. Imlifidase is particularly exciting. It provides rapid immunoglobulin clearing, and VSO data have been encouraging. We are all watching for the phase 3 results expected in late 2025. And the last key point is that special population requires adapted approaches. Double positive patients need maintenance immunosuppression because their relapse risk is higher. A typical presentation requires a higher index of suspicion and tailored diagnostic strategy. Pregnancy and pediatric kids and post-transplant patients each require specialized management with more careful adjustment. And looking ahead, the future is promising. Advances in immunopathology, biomarkers, and targeted therapies are opening new doors for improving prognosis while reducing treatment toxicity in this rare but devastating disease. Ongoing trials will continue refining our approach and ultimately help us deliver more personalized, safer, and more effective care for our patient. And before I finish, I just want to say thank you all for your time and your attention today. NGPM disease is a tough condition to manage, and and the fact we continue to improve outcomes is really a reflection of how much we are learning together as a community. I hope today's session gave us something practical, something thought provoking, and maybe even something you can take back to your patients tomorrow. I'm very happy to hear your thoughts, your questions, and your comments. Thank you again. It's truly been a pleasure being with you, and goodbye.